Welcome. It's good to be with everyone. Thank you for joining us, and thank you for sharing some interesting cases. This first case, Dr. Lynn sent to me, a patient from her hospital, has a lesion in the lung, which we will see here on the radiograph. So it's quite massive here on the right lung, and it appears to involve more than one lobe. And of note, it was kind of wedge-shaped and not rounded edges. It was very linear shapes. Here's the other images here. I believe this also is a video. Yes, here we go. It also looks as though it has some cavitation. Right here, I think we see some hypodensities in the middle of this. So when we look at the digital slides that you've given me, I think we have two of them. We see this picture, which shows us a couple of key features. One is a lot of dense hyaline collagen, this very pink collagen. Here's the admixed anthracosis from the lung. And then we see some residual alveolar and bronchiolar spaces with chronic inflammation and some reactive pigments and sort of cuboidal type cells. And all along this biopsy, there seems to be a very consistent pattern that's what we're seeing. It's the pigmentation, a few air spaces, and collagen with chronic inflammation, which in areas is this very hyalinized keloid type of cartilage. We'll go and look at one more slide, which I think you have several more, another core biopsy. This shows, again, that same pattern, however, with just a lot of collagenous tissue, some mixed inflammation, anthracotic pigment entrapped in the cells, in the stroma, and a few residual small and variably sized air spaces with the features that we see here. Here's the keloidal cartilage, keloidal collagen here. So you had raised the differential diagnosis of a hyalinizing pulmonary granuloma, which is certainly very consistent with this process, especially this keloidal collagen. There might be a few other things to consider in this differential, such as a rheumatoid lung disease can sometimes give you a dense collagen and this sort of reactive appearance. But I don't believe this patient had rheumatoid disease. And then as long as, it's certainly possible that this is all secondary to a long-standing pneumonia in a patient who has chronic pneumonia. But that is, again, a little bit of an unusual picture because usually you'd have more evidence of residual organization and so forth ongoing. So organizing pneumonia, I don't think would usually have this type of a picture. But the problem here, as Dr. Shilan from Viaduct points out, is that this is such a large mass that it's difficult to be confident that what we're seeing here is really responsible for the entire process. And that's something that we as pathologists struggle with. We get very small samples, and then we have to predict what a larger tumor mass is going to look like. And so we're at the mercy of the either the interventional radiologist or the endoscopist or whatever who biopsies this material to provide us a sample. If they don't provide the most representative sample, all we can do is be descriptive and provide an evaluation of what we think it might be based on this very small sample. Dr. Lin or others, do you have any other thoughts or questions about this?
How about the diagnosis? How about the diagnosis? This reason. Exactly, what do you think?
Could this be a viral pneumonia? Is that the question?
No, exactly. What about this reason for diagnosis?
I like your diagnosis of hyalinizing pulmonary granuloma. I think that fits best with what we see and what we know. You know, I can't diagnose malignancy without malignancy. I mean, this could be at the edge of something, but based on what you've given us, I think that fits best. So this always is the dialogue we have with our people when we meet in a tumor board. We show them what we have, and you know, we ask the question does this explain it? Does this fit with what we see clinically, radiographically, endoscopically, and so forth? And if it doesn't fit, if there's a then we can have the dialogue of how we can settle that, either to get more tissue or do more studies or repeat the analysis, radiographs or prior biopsy. So to see what identify that may explain it better. But that's where the dialogue, the exchange of ideas and findings with our clinical colleagues in tumor boards and so forth is so valuable. So I think this is a great case to illustrate that challenge. Even if the answer at this stage may not be the most satisfying, it's kind of where we are and the point at which we have to work going forward. So let me if there are no further questions, let me share a couple of cases that I've been working on. I've been putting together some cases of myxoid tumors for a lecture that I'm going to give. And I thought I would show you some of these myxoid lesions. So can you see this? Well, let me stop the share and reshare again so that it will pick up the right screen. Okay. So the classic description of myxoid tumors goes all the way back to Dr. Virchow, although some people had even earlier than that identified these tumors as being gelatinous and resembling the kind of tissue that we see in the umbilical cord. And so the umbilical cord is kind of the prototype. And this is an example of the classic tumor, the intramuscular myxoma that I think was the prototype. Now, we know it's intramuscular because usually we'll find somewhere in the lesion these small atrophic strands of skeletal muscle, which you can see here. And these are not very interesting histologically because there's so much empty space. But the cells are relatively widely spread. They're very bland. They're spindle to stellate shaped. And there's a little bit of collagen in the background. There may be a few vessels, but they're usually very rare in the intramuscular myxoma. So there are decidedly very few vessels in this intramuscular myxoma lesion, as you can see here. Now I have another example, another intramuscular myxoma, just for comparison. They usually have a little bit of a capsule, but sometimes because of their presence in the muscle, it's just the muscle fascia that contains them. And this one, I think, has a few more vessels evident in it. But as you can see from low magnification, they're very sparse. Here's a few vessels over here, but they're really quite rare in these lesions. So that is the first prototype of myxoid soft tissue tumor. Let's look at another soft tissue myxoid tumor. This is the angiomyxoma, which has a little bit more vasculature to it, but is very, very similar. This lesion tends to be more superficial and has these very delicate, thin vessels, as you can see here. But other than that, it looks very, very similar to the intramuscular myxoma with just very bland cells, abundant myxoid matrix. And here you see some of the small, thin-walled vessels that are associated with the angiomyxoma. Now, in terms of differential diagnosis and behavior, not a huge difference. There is a small recurrence risk, but no metastatic risk. And so if you make this diagnosis on a frozen section or something like that, they don't need to do a lot of aggressive therapy. They just need to get it out as comfortably and so forth as they can. Now, in contrast to that, there are deeper angiomyxomas, and that is what this case is. And these are the lesions that occur in the usually in the anogenital areas, most frequently in women. And although they're termed the deep angiomyxomas, they actually can come fairly superficial and close to the skin. As you can see here, we're in a submucosal area. There's ulceration. And then we have this very bland but fairly uniform and altered stroma. Now, one thing that I have found useful is that in the aggressive angiomyxoma, we tend to have vessels of varying caliber, varying size. So you'll have some larger vessels, some very thin-walled veins, and some capillaries as well. So in contrast to the intramuscular and superficial angiomyxoma, which tended to have vessels of just one size, very small. In the aggressive angiomyxoma, the vessels are more varied in their size. Now, it's said that on some of these vessels, you can see the smooth muscle cell sort of radiating out off of the vessel. I don't find that very often as a very useful feature, but I think maybe that's sort of what's happening here, where there's a little bit of filleting around this larger vessel, or maybe a little stranding off of some of these areas here. This tumor has been described as being specifically positive with HGMA1. But in fact, I'm not sure I completely agree with that, because I've seen a few other anogenital tumors that were not superficial, or excuse me, aggressive angiomyxomas, which also stained positively with HMGA or HGMA1 as well. So that's maybe a little bit of a false hope that that stain would be specific. It does seem to be related to the molecular genetics in these lesions. Now, this lesion, as you know, has no metastatic potential, but it does have the potential for recurrence, and it also can be very deeply penetrating because it tends to be deep. So you may see a superficial component like this that's near the surface, but it may extend quite deeply into the pelvic soft tissues and involve the anal levator areas, and even up into the periadnexal areas of the genital organs. I have one more example here that may help as well. That's kind of a nice example of this. Again, it has it's a superficial sampling, but as we look in here more closely, we can see that there's this altered stroma. And this can be very deceptive. If you just are thinking of, benign superficial lesions that are very bland, you could easily mistake this. And the clue here is that this altered tissue goes very deep. And again, you have these variable sized vessels. It's very bland tissue, and this is where a good degree of caution needs to come into play. Let's see here. Did we have one more? Now, there are a couple of other lesions that have myxoid in their description, but which have a very different presentation or location-wise. One of these is the chondromyxoid fibroma, which typically presents in the bone. It's a bone lesion. It's not a skin or soft tissue lesion, but it does have considerable amounts of myxoid tissue, and sometimes to the inexperienced may be concerning for a myxoid chondrosarcoma or something of that sort. The key is that this is usually a metaepiphyseal lesion, which is very low grade. It may be lytic. It may look like a giant cell tumor or something like that. But here you see this background. It's very myxoid, and you might not think of chondroid in the first description because it doesn't really form good chondroid tissue, maybe other than a few areas, maybe some areas like this, where you tend to have a little bit of a sense of a lacunae formation, but not very convincing cartilage tissue. That said, though, there are really no other intraosseous lesions that look quite like this. So if you can remember this lesion and the morphology here, a little bit of vasculature in the background, myxoid tissue, and this sort of chondroid nature to it. Looks like, myxoid chondral tissue. Then you should be able to make the diagnosis without too much problem. Usually there's no osseous formation, although you may get a few areas like this where we have increased cellularity and maybe even a little bit of pseudo osteoid here, like substance here. But I think if you polarize this tissue, you would find that if you did polarized light exam, this would not usually polarize. This is still a chondroid matrix in these tissue areas. So that's the chondromyxoid fibroma. Now, I think we may have touched on this one previous time, but I'll mention it again here. This is a lesion which we need to think about when we get a needle core biopsy of a soft tissue lesion that has a lot of myxoid tissue. So here is a couple of needle core biopsies, and we have varying cellularity, myxoid areas, some open clear spaces, a little hemorrhage, maybe some vessels. And you were kind of being asked to say, is this, what kind of a tumor is this, and what should be done? So looking at this lesion, I think there are a couple of things that kind of come into the differential diagnosis. One is, could this be an epithelial tumor? There is one particular myoepithelial tumor, the myoepithelioma or myoepithelial carcinoma, which can have this kind of interlacing anastomosing bands of cells like this we see here, as well as a very myxoid background. That usually looks a little bit more epithelioid than this, but it can have some similarities, and so you need to think about that lesion as a possible differential diagnostic feature. The other thing to pay attention to here are these rounded lipid-like droplets, because a myxoid liposarcoma can also have this variable morphology. As you recall, that was initially thought that round cell liposarcoma and myxoid liposarcoma were different entities, but in fact have been found to have the same driver mutation, the same fusion gene, and are now grouped as the same lesion in terms of prognosis. But looking in some of these areas for the possibility of lipoblasts may lead you to find a few cells like these. These are not in good focus here, I apologize. Let's find some better ones. May lead you to a few areas like this, where you've got a lot of myxoid tissue, and then these rounded cells, many of which have sort of peripheral nuclei, almost signet ring cell, and some of which, if you look far enough and closely enough, you would eventually be able to recognize as lipoblasts, especially when they have this kind of multinucleation. Now, with myxoid liposarcoma, one of the characteristic features is that you get this kind of bilobed lipoblasts. So here's one, I think, right here, where there's just this very little thin rim across a single nucleus around this cell. Or one, here's a nice lipoblast here, where you've got multiple lobes and they all indent the nucleus. Another one over here. So in myxoid or round cell liposarcoma, you should be able to identify lipoblasts, and they will be very helpful to you in the diagnosis. The most useful thing, however, in this diagnosis really is the identification of the fusion gene. And the fusion gene is usually linked to DDIT3 as the partner. That's the common partner. And it can be linked to FUS or a number of other possible fusion partners. But a FISH study that includes DDIT3 or a FISH study with FUS can usually detect this tumor as having that sort of mutation pattern. Now, this is important to make this diagnosis on needle biopsy if possible, because that's going to change the management of the patient based on this finding. That will lead to a more aggressive surgical approach as compared to, say, even myoepithelioma or some other myxoid or chondroid type of lesion. The other consideration here might be a extraskeletal myxoid chondrosarcoma, but I've got an example of that to show you for comparison. So let's jump to that lesion here. And I'm sorry, this is not a needle core biopsy, but extraskeletal chondrosarcoma also has this myxoid change. Here, however, we shouldn't be finding lipoblasts, and we'll see a more, bluish chondroid myxoid matrix. But here we note that the cells do tend to sort of line up a little bit. There's a little bit of a chaining of these cells. And we don't have quite classic lacunae like we would in a true chondroid neoplasm, although maybe an area like this represents some lacunar formation with just multinucleation in the lacunae. The matrix does have this tendency to bubble, as you see here. And so sometimes those bubbles, if they overlap a cell, they might be potential to mistake them for a lipoblast or something like that. But in general, that shouldn't be really very strongly in your differential. Additionally, you'll usually have a little bit more fibrous matrix between the lobules of this lesion. As you can see here, there's some lobulation to it, and we have this more dense collagenous tissue, which we don't usually see in a myxoid liposarcoma. Let me go back here just a second here and look at that again here, just to show you another example of a myxoid liposarcoma. Here's one, and you can see, although it's lobulated, most of the lobules do not have much in the way of intervening fibrous tissue. Very minimally up here at this end, where it's sort of grown around and through the muscle. as it's spread, but not the same degree of lobulation that we were seeing before. So those are a couple of the relatively monotonous sarcomas that have myxoid changes. Let's talk for a few minutes about fibrosarcoma, which also has this myxoid term in the name. Most commonly, myxofibrosarcoma is a high-grade sarcoma. And so that is one thing to remember, that it can have a fairly high degree of pleomorphism, which you can even identify at this magnification. You can see giant cells, pleomorphic cells, and so forth. There is a lot of myxoid matrix here again. But here we see the nuclear pleomorphism, multinucleation, a lot of hyperchromasia to these cells. So we would classify this as a higher grade sarcoma. The caveat here is that myxofibrosarcoma does have some recognized low or intermediate grade tumors that can also have this appearance. Generally speaking, however, this is a tumor of older adults, and it tends to be a deeper tumor, whereas the thing that we are thinking or concerned about, low-grade fibromyxosarcoma, usually is younger adults and usually more superficial, above the superficial fascia. So I'm going to show you a couple of other myxoid examples of this tumor, which illustrate this challenge. So this also is a deep lobulated tumor. It has abundant myxoid stroma and some zonation and so forth, with some less and greater areas of myxoid change. But as we look at this tumor, it's still relatively monotonous. There is some pleomorphism here. Notice we've got some larger nuclei, and some of these nuclei are a bit on the atypical side of things. But it's not a highly pleomorphic sarcoma. It does have a lot of this myxoid tissue and some less myxoid areas as well. Now, if we contrast this to, let's see if I can find it here. Well, I don't think I put an example in of low-grade fibromyxoid sarcoma. I didn't put in an example. So I'll apologize on that. Low-grade fibromyxoid sarcoma tends to be a little bit more lobulated and have areas of separation. But there's also another clue, and that is that if you use MUC4 or EMA, you can usually identify positivity in the low-grade fibromyxoid sarcoma, which you do not find in the myxofibrosarcomas. So different ages, different locations, deep versus superficial, and a little bit of differential staining with MUC4 or EMA that should help you make that differentiation. So that's a little bit of a sort of a pitfall and a challenge, and probably what keeps soft tissue pathologists employed for consultations and so forth, but can be used. Let's see, what else do I have? I have a couple of other entities that I thought would be interesting to look at. In contrast to the intramuscular myxomas, which we highlighted at the beginning, there is also a tumor that occurs around joints that is also important to recognize, that has a very bland myxoid appearance, as you see here, somewhat lobulated, and a lot of myxoid tissue, hardly any vessels. This is what is called the juxta-articular myxoma. So here's a few small vessels, a lot of very bland, spindly shaped cells, and a little bit of lobularity to this lesion. It is most common around the knee, but other large joints can also have this presentation. And it can arise near them as well. It is distinct molecularly from the intramuscular myxoma. This lesion has a little higher propensity to recur. It is associated with some mutations in the GNAS gene, similar to some other tumors that you see intraosseously sometimes, fibrous dysplasia and so forth. So this is a good one to recognize and to be aware of in someone who has a mass around their knee and so forth. This might be mistaken for giant cell synovitis or something, but there are no giant cells, and it's a very different presentation of that type of tumor histologically. But clinically, it might present in a very similar way, involving the soft tissues around a large joint with some degree of nodularity. So I have another interesting tumor. This is not one that I've seen very frequently. This also has the myxoid character. And this one also has some variability in terms of behavior. This is the ossifying fibromyxoid tumor. Now, most cases of this, as you can see here, are superficial. And usually the pattern is this. The central area is the fibromyxoid area, and the ossifying component is usually peripheral at the margins of the myxoid tissue. So here we see the myxoid tissue, a little bit of vascularity to it. As you can see, some dilated vessels, and then little cords of cells with intervening myxoid change and collagen. And then at the periphery of the tumor, we get areas of dense fibrosis and then secondary ossification as a response or whatever to this tumor. This is different type of tissue that's forming the bone. It looks like it's forming in the dense fibrous tissue of the capsule. And it looks like it's more kind of a woven bone type of ossification. But it's fairly characteristic that at least in the benign lesions, it's quite commonly at the periphery of these lesions. Now, the little challenge with this case or this tumor is that it does have a recurrence risk, but there's also a rare circumstance where there is a malignant variant or a malignant version of this that will metastasize. And so because of that, there's a bit of concern or anxiety with making this diagnosis because of that possibility for the eventuality of metastasis. Features that would tend to suggest malignancy, malignant behavior would primarily be cytologic cellularity and atypia. Mitoses, of course, we might think about necrosis. Those are not as good a predictor as just the cellularity and so forth. Now, another feature that can be seen with this and is perhaps more prevalent in the malignant versions, is when the ossification is central or not at the periphery, as we just described. So here's a case where you have the ossification occurring right out of the middle of this tumor. You can see it's got this myxoid character, a little bit of stranding of some of the cells, but then this woven bone forming right out of the central portion of the tumor. And so this might be a marker to be more concerned, to look for mitotic activity or atypia, and raise the possibility for metastatic disease from this lesion. I'll show you another example of this tumor here. And in this case, the tumor is kind of multifocal here in the deeper soft tissues just above the muscle. And as you can see here, we have 1, 2, 3 of these lesions that have nice, osseous rims around them. So here's one up here. And we have the nice ossification area here and the central area, myxoid and fibrous tissue, the ossifying fibromyxoid tumor. But not all of these little nests of tumor are quite like that. And notice here we also have some degree of extension beyond the osseous rim, if you will, sort of penetrating the capsule. This is not a marker for malignant behavior, but certainly helps to explain some of the reasons why this lesion has still a pretty high recurrence risk, somewhere between 20 and 50%. So just shelling out the bony part may leave behind a little nest like this, which could then go on to develop into a recurrence. I think it's interesting to note that this has a little bit of sort of more epithelioid appearance comparing to the fibromyxoid tissue in the center of it there. But we see some of the variability in this lesion in some of these other areas as well. And here you might wonder if we're beginning to develop central ossification. I don't think so. I think this is still just a dense fibrous tissue. So those features, the peripheral rim of ossification, the propensity for local recurrence, and some of the benchmarks to be aware of in terms of predicting potential malignant behavior are of interest with this particular neoplasm. So let's see, is that, I think that pretty well wraps us up as far as the cases I had presented to discuss. Oh, actually, I have one other example here, just for fun. We also are aware of myxoid tumors that occasionally present in the heart. Virtually the only tumor we see in the heart itself is the cardiac myxoma. This lesion oftentimes looks more like an organizing thrombus than a true myxoid tumor, but it does have this sort of myxoid ground substance in background. But notice here it tends to have a little bit more of a surface endothelialization type of pattern, where the endothelium has begun to spread over the surface of this and try to organize it into tissue. So the cardiac myxoma can also be considered one of these myxoid neoplasms, usually not a diagnostic problem, although there are some variants. I think, Dr. Han, you're on here, and I seem to recall that we had one at K Hospital while I was there a few years ago that was quite confounding from the atrial appendage that was thought to be a myxoma, but had some heterologous elements, some glandular elements and things like that that can be sometimes quite confusing in terms of the diagnosis. So any questions any of you want to bring up about any of these cases or slides we've discussed tonight or this morning?
That was helpful. In my understanding. In the besides liposarcoma, the most important thing is the finding of lipoblasts. It's right because we cannot do the fusion gene now. So in this case, is the lipoblast is the cruise criteria for us to diagnose the liposarcoma.
Yes, I think that's the case. That's a very reliable predictor. The challenge is, however, that when you have an exclusively round cell variant, very few lipoblasts may be identified. But in the myxoid liposarcoma, the more myxoid areas should have ample numbers of lipoblasts to help you make that diagnosis. But if you can't do the fusion gene, you may miss some of the small round cell liposarcoma component. Usually they're mixed up, and so you should, if you get a good sample, you should be okay. But there are always those cases where you just got the round cell component.
Yes, thank you, Professor.
Well, I think I'll let you get on to your day's work. I appreciate your willingness to adjust to my schedule, so we have it today rather than Friday. But I wish you all a very a pleasant weekend. And I know that coming up the end of this month is a holiday. And so I think we probably may not meet until after your holidays are over. Hopefully that will be a good experience for all of you. So thanks so much, and we will talk to you after the holidays.
Thank you, Professor.
Thank you, Professor. Wish you a happy weekend.